So I think, Mauricio, we'll go ahead and get started then. I'll do an introduction, as I said, and then we'll turn to you. So good morning, everyone, and thank you for joining today. This is John Samet, the Dean of the Colorado School of Public Health, and I'm delighted to introduce my long-term friend and colleague, Dr. Mauricio Hernandez from Mexico. Just by way of background, Mauricio is a physician trained originally in Mexico with a PhD in epidemiology, or I guess SCD in epidemiology, officially from Harvard School of Public Health. He's had a long and illustrious career in public health in Mexico, working at the National Institute for Public Health, including being its director, being undersecretary of health during a particularly challenging time with the H1N1 influenza outbreak. And most recently, Mauricio is director of social and economic benefits at EAMS, the Mexico's National Social Security Institute, which provides healthcare coverage for those employed in Mexico. An enormous group of people, and Mauricio is director of the team concerned with social and economic benefits, which covers many, many topics. It's now about a year and 3 months ago that we had a joint meeting and workshop in Mexico City to explore opportunities for collaboration. We found many. And then the pandemic happened, and we have stayed in touch about the possibilities, but this seminar is an effort to sort of restart thinking about those collaborations, both now as Mexico faces the COVID-19 pandemic, and EAMS grapples with what they have to do, and then hopefully looking to the future when we might even get on airplanes and travel back and forth and work directly together. So Mauricio, thank you and your team so much for joining, and I'll turn things over to you.
Well, thank you very much for the introduction, and the invitation is a real pleasure to be here with your faculty and with the Colorado School of Public Health. I was laughing because we thought that H1N1 was challenging, and now we know it was not so much challenging. That a real epidemic is this COVID-19. Is really making us think a lot of what we should be doing in the future, which I hope we now learn that we really need to take these things very seriously. So I have prepared some slides regarding a little bit of Mexico, a little bit about the Mexican Institute of Social Security, and the work we are doing in the occupational health department of the Institute. So let me share my presentation. Just one moment. Okay. And I assume that you're seeing it completely in the screen.
Yes, Mauricio, it's good.
Okay. So starting with Mexico, we are a federation of 32 states. We are the 15th largest country in terms of geography, and we are the 11th most populated country. Right now, we have close to 124 million residents, of whom 70% live in urban areas. And it's a young population, 27% less than 15 years and 7% over 65 years. We have had an increase in life expectancy up to 75 years, but in the last 4 or 5 years, life expectancy has not increased among male but is slightly decreasing among females. We are a country with high inequalities. 58% of people in the rural areas are under poverty and 39% in urban areas. And the main causes of death in Mexico are diabetes, ischemic heart disease, and homicide, especially among men. Now, our health system rights are based on employment. People who don't have employment or formal employment receive universal public assistance from the states and the federal government. And we have a small private sector that provides care to 6 million persons in Mexico. The workforce, which is what we will be talking very much about today, we estimate that there are close to 56 million workers. And from those 56 million, 23 million are in the formal sector. And from those 23 millions, the Mexican Social Security Institute, say our institution, provides insurance for almost all of them, so close to 20 millions. So the Mexican Social Security Institute, as we call it here in Mexico, IMSS, is a very complex institution. We collect taxes from employers to provide the insurance. So we are the second tax collector in Mexico, and probably the second largest buyer of supplies. So we provide health services to all workers which are in the private formal sector. We provide also insurance for disability, for life. We administer pensions, and we also provide workers compensations for labor risk and insurance for employers. We provide healthcare, but at the same time, we also collect the risk premiums from employers. So we are in all the businesses part of the health, of providing health. One of the services that we provide, or the benefits that we provide, includes a universal monetary subsidy for short-term disabilities. And all our workers have access to this benefit when they have an illness or injury. And basically, we are going to be talking very much about what have we learned regarding COVID-19 using this system. So in terms of numbers, we provide insurance for close to 20 million workers and their families. We are a very big institution. We have almost 470,000 employees. We have clinics and hospitals all over the country. 1,200 family medicine clinics, 284 hospitals, and 38 referral tertiary care centers. In total, we have close to 5,000 medical units, and our budget is approximately 2 billion pesos a day, and that's only in that also includes the pensions per se. And every day we provide 518,000 consultations, 923 births every day, almost 3,000 surgeries. We see or resolve 43,000 emergencies, And we take care of 250,000 kids that have their daycare with us, and we take care of close to 4 million pensioners, and we provide them with monthly installments per se. The area that I have the pleasure to coordinate is a very complicated area because it includes what we call all the social benefits plus occupational health. The issue of us being in charge of occupational health is recent. It was a change that took place 2 years ago, and originally occupational health was in the medical area, but they decided to change it to the social and economical benefit area. So we start in the with our services by protecting pregnant workers, and that's the first contact that we have with our future citizens, and we provide this maternal leave, which in Mexico is by law. Then we receive close to 250,000 kids in our daycare centers, and there we develop and contribute to cognitive development, and we have a very strong program on healthy nutrition. And this is, I think, one of the most cost-effective interventions that we provide. Then we go all over the lifespan. We administer sports centers, recreation facilities, family vacation centers, and cultural activities. We have 38 theaters, 1 movie center. We have 4 vacational centers, very nice. So if you ever decide to go to Mexico and do hiking, we have 1 which is close to the Malinche. So it's a very nice setting. Then from there, we move to the occupational health, and we are responsible for keeping the work environment healthy and safe. And we also administer all these subsidies that I was mentioning before. And we also prepare our workers for retirement. And finally, we help them in the last transit to the other world with 18 funeral houses that we have around Mexico. And we work with 5 insurances. One is the working compensation. The other one is disease and maternity. The other one is disability life, retirement and unemployment, and also the one that covers the daycare centers and the social benefits. Our affiliated workers, in theory, they have the right to receive daycare centers from IMSS, though we are not close to having a 100% coverage. We probably have like 10 or 15% coverage, but that's close to 250,000 kids that we have in our system. In terms of the work we do on occupational health, we have 2 major strategies that we are pushing forward during this administration. One is early return to work, because we detected that workers lose working days because they don't get the proper attention or referral to the different specialties that need to take care of them. So we are working on this with the aim to decrease the load of the short-term disabilities. The other one is we are gaining also focus in health at the work centers. This is an adaptation of the total work health program that is being implemented in the US, and we are there focusing a lot in smartphones and interventions that we can apply on a massive scale. Just to come into the topic of today more closely, the insurance that we provide is we cover injuries at work, also injuries on the transit to work. We cover occupational disease and also death as a consequence of a work risk. And with this policy, we provide, on one hand, medical services, surgical and 100% pharmaceutical assistance, hospitalization, any prosthetic or orthopedic appliance that might need, and rehabilitation. And we also provide preventive services in companies. We only work with, in terms of consultancy, we don't have the power to do inspections or to find companies for, say, occupational health. In terms of monetary subsidies, we provide subsidies for short-term disabilities, and we provide compensation. And as I mentioned, we also are in charge of the pensions. In terms of the collected primes from employers, we collected 45,000 million pesos. So that's why IMSS is a complicated institution, because we not only provide, we collect, we finance all the system. So it's a little bit difficult to administer. Well, I will come back. I will come into a little bit of details about how are we doing with COVID-19. From February 28th to December 31st, we have officially confirmed 1.8 million cases. That means PCR are confirmed, which you might think is a very small figure for a country with 120 million. Yes, it's because we don't do enough testing. Now, in terms of the official number of deaths attributed to COVID-19, we have 122,000. These are mostly deaths who have a positive PCR test, or they are epidemiologically linked to a contact. However, a study done by the Ministry of Health has shown that we have 294,000 excess deaths, which is an increase of 40%, which is very, very, very high. I don't know the figure for the US, but for France, this figure is about 8% excess death for all causes. In terms of what happened in Mexico, in political events until March 23, we finally recognized SARS-CoV-2 as an infection of national priority. And on April 21, we entered the epidemic phase, and we enabled social distance measures that included closure of school, suspension of non-essential activity, self-quarantine for people over 60 years old, and younger workers with underlying chronic conditions. But it's very important to mention that we did not implement a full lockdown. It was basically voluntary. Reopening plans were started on May 13 and became effective on June 1st. From May 13 and June 1st, we, the Social Security Institute and the Ministry of Labor, Health and Economy, we issued mandatory guidelines. And these mandatory guidelines were supported in a very ambitious massive online open courses that we now reach over 10 million workers. During this phase also, we granted the recognition as essential activities to construction, mining, and auto transport or auto spatial fabricated industries. This last group was basically to hook with our duties with the North American Free Trade Agreement, and that's why they were authorized to reopen. Also, it's important to say that our control strategy led by the Ministry of Health was based in a sentinel surveillance technique, which really focuses more on monitor than on widespread testing or contact tracing, and that's also part of the impact that we see in our figures. So this is the results of our massive online courses, MOOC. MOOCs are, as you might know it in English, we have 12.5 million enrollments. We had a completion rate of 80%, and we were, I mean, in terms of time, we completed 8,000 days of training, which is quite good. We had 42 active courses, and 13 are related to the new normality or the reopening of industries. So in terms of the short-term disability, which is most of the data that we are going to be discussing today, this short-term disability is when a worker has an injury or a general disease that prevents him to fulfill his working responsibility. He needs to go to his family doctor or to the emergency room. And it's important to say that this has to be certified by an IMSS physician. So that is very important. So during the consultation, his family doctor decides if the worker can go back or he will need up to 3 days, more than 3 days to be covered. And if the disease is a general disease, then the worker is entitled to 60% of subsidy of his daily salary, starting at 4 days. If the disease is related to occupational origin, then the worker is eligible for 100% subsidy and is starting at day 1. So it's different. This is, I think, important to know because given that COVID-19 is labeled as a general disease mostly in Mexico, or is perceived as a general disease mostly by our family physicians, most of the temporary disease claims that we have are more likely to represent disease with moderate symptoms. So we need to have that in mind. Okay, so from the claim that is digitalized, we can extract information such as age, sex, medical unit, and very importantly, all diseases are coded by the ICD-10 diagnosis system. And we can also get the number of authorized days by the physician. And if the worker has an extension of the original temporary disability, we can keep track of the new extensions that he or she is getting. From the medical unit, from the claim, we can also obtain information from the businesses, and so we can know which type of economical activity this worker is working and what type of risk. Also, we can link the claim to the medical records and know how many receive a PCR test or what was the result, or we can link also with hospitalizations or death registries. So we have that type of information, and I will show you some. So in terms of the data, 95% of the temporary work disabilities, short-term disabilities, have their ICD code, and we have only to recover 25% from the scan records, which is, I think, good. If the diagnosis change, then we keep the original diagnosis, but we can also look at different diagnosis, subsequent diagnosis. This is going to be very important to monitor the long-term complications of COVID-19, because we are going to be able to follow workers long-term with their temporary disabilities for other disease. For this data that I'm going to show you, we included all ICD codes with acute respiratory disease, influenza, pneumonia, and any word related to COVID-19 and suspicious and other respiratory disease. So we have a very ample definition. And this is how it looks. It's a little bit difficult to follow this graph, but this is what you see here is the epidemiological weeks from epidemiological week 1 to 52. In the bottom lines, you can see what was the demand of temporary disability claims, short-term disability claims for years 2018 and 19. And then you see all what has been the claims for year 2020. We have over 1 million excess of claims for short-term temporary disease for respiratory disease. And here you start seeing year 21, starting in the first epidemiological week. And as I was mentioning, we are going now down in terms of claims demand. And so this system, we can have a national view. Here, the different bar colors represent different diagnoses. The magenta color represents respiratory disease. The brown color represents influenza. And the little dark brown here at the bottom represents pneumonia. Here you see year 2009 with the traditional peaks that we have in the winter. at the beginning of the year or at the end of the year. And then we start 2020, and here you see different events, and we went into April, when we went into the social distancing activities. So we were able to stop the peak, but as soon as we reestablish, which is this dashed line that's in May, then we saw an increasing demand for short-term disabilities. And you can see that nationally, we had two peaks and then one final peak at the end of the year. All these are claims that are, are claimed by the workers with their family physician, and they all have clinical diagnosis. The green one is COVID-19. The magenta one is acute respiratory disease. And you see here that they're not making any diagnosis of influenza, very little. And there is this diagnosis of pneumonia that goes all year long. Now, this is the national figure, but we have the possibility to build up the epidemic curves for the different states. For example, you can see here Campeche and Chiapas, Chiapas, which are in the south. And in the south, we had a late peak with influenza. Also, if you remember, Yucatan is also in the south, and Veracruz and Tabasco had a very high peak in the summer. The other states, we had peaks, some all year long, like Baja California, had a first peak, second peak, and a third peak, which followed very much also the peaks that were observed in California, and basically in San Diego. So this system provides us with the opportunity to see and to help the surveillance at the state level. Furthermore, we can also have a view at the site of the business or the workplace, depending on how it is registered. So here we display this graph in which we have the size of the companies. It goes up to 10,000, the biggest. And then here we have, in a log scale, the percentage of workers that have had a short-term temporary disability for COVID-19 or respiratory disease. And well, you see two things. First, there is a big dispersion. Second, there are companies with the same size that have no cases or almost no cases, and companies who have been very busy with high epidemic level at their premises. So we can, in this dashboard, we can click the point and it will take us to the company which is representing this dash point. Sometimes a point may reflect one single company, for example, like Ford Motors Company, but sometimes it may reflect a conglomerate, like, for example, in convenience stores. So then we are not able yet to have the single company, but this has been very helpful for surveillance. Well, now coming to the results that we have, this table it classifies the workers by the economical activity, which is in the hard green. And you see here we have the insured workers. We have almost 19.7 millions. And then we have the different sectors: agriculture, mining, manufacturing. Here we have 5.4 million workers in manufacturing, and the number of work days that has been lost is very high, 5,000, close to 5 million workers, close to 5 million working days lost. And the estimated excess, when we compare this season with 2019 and 18 and 17, we have a sevenfold increase in the number of days that were lost. And we have some subgroups here, and the one who had the biggest impact is the transport equipment. Remember that I mentioned that this was granted degree of essential industry, so they started really rapidly, and well, they were heavily affected. I just want to also attract your attention to this economical activity, which is social and community services. Here we have a mixture because we have educational services and arts and entertainment linked with healthcare and social assistance and social security. Here, social security is us IMSS. And as you can see, IMSS has the highest impact among all. Mortality per 10,000 workers was 15. The only one which is behind us is the electrical company, which is another large state-owned company with them. In comparison, these healthcare and social assistance are basically private healthcare, and they're high, but they're considerably lower than us. Here in these graphs, maybe it's easier to see them. Here's the mortality at 5.9 per 10,000 workers, and the hospitalization rates at 23 per 10,000 workers. And here you see Social Security, which is basically IMSS, is among the highest. Again, water supply, and social and community services that regroup these three is also high. Agriculture was had a low impact, mining as well, and the other one which I was mentioning was the state-owned electric company. In terms of percent of temporary work disabilities, this will be, say, close to estimation close to estimating an attack rate of COVID-19. The one that, not surprisingly, has the higher attack rate is the IMSS, Social Security, with 32%, and healthcare and social assistance with 15%. One explanation might be that IMSS workers know their rights very well, and because they have a special agreement in their working conditions, in their working, the working agreement, IMSS physicians or IMSS employees receive 100% of their salary from day one. So it might be that because of that, they are more eager to claim this temporary working disability. While private sector were not claiming COVID-19 as a occupationally related disease, and there is this almost half attack rate. So these data are also very interesting to help us to estimate what has been the attack rate in different sectors. Again, agriculture has one of the lowest, but educational and art recreation has also one among the lowest with 3.7 attack rate, which reflects that this sector is basically or working at home or not performing at this time, because arts and entertainment has been shut down and has not been restarted, and educational services are all delivered by distance education. So teachers and professors are working from home. This is how the epidemic curve looks for the different sectors. Here are the 9 sectors that Mexico uses to classify industries. And you can see CFE is our National Commission Federal Commission for Electricity. So you see it has a very, very, very important attack rate. Is among the highest. We still don't know why. We don't find a reasonable explanation. Agriculture is low, and social services here is high as well. Mining and extraction has been low. Manufacturing is being high, and construction, surprisingly, has been kept itself at a lower level. Now, when we go into these subsectors, then we see here is our epidemic curve for IMSS. And as you see, we are among the highest ones. I want you to notice that the scale here is higher in comparison with all the rest of the graphs. So this goes to almost 120, while the other ones go to 80. So it's much more higher, and it's not surprising that the areas that were closed, for example, restaurants that have been closed most of the time until week 28, that they start reopening, then we see an increase of cases. Retail stores that have been open since the beginning because they are considered essential, they have remained high at all levels. However, they have been stable in the last days. So with this analysis, we can decide also, or we are trying to encourage a change in our vaccination policy that is only focusing in people over 65. And we are hoping to be able to at least change the perception that in addition to health workers, we might include other essential workers as candidates for vaccination. So if you may, I may stop here to provide for questions and discussion, as John was suggesting at the beginning, and I remain attentive to your questions or comments. We have another point to share with you, which is the work we are doing in workplace outbreak detection. But if we have time, then we can look at that. But maybe I will stop here to get your questions or comments.
Great. Thanks so much, Mauricio. I have to say I'm certainly impressed by the wealth of data that you have and the opportunity to learn from it. I was particularly struck by the opportunity for you to look at what happens with those workers who have had COVID-19 and look longitudinally at both their work and medical history. It seems like a really important opportunity. I think what I will do is suggest there was one question in chat already, but maybe put your questions into chat, and if we want to elaborate more, we just invite you to speak. So a couple questions that came in already. One is, why do you think there are not so many peaks? This goes back to your breakdown by geography. Not so many peaks in El Distrito Federal in comparison to the states outside of the capital, the difference in distribution over time.
Yeah. Well, the Mexico City area is a hub for satellite populations of the state of Mexico, Hidalgo, Morelos, Puebla. So the locking down there has been, I would say, very relaxed and has not been enforced. So what we see is this sustained transmission in the Mexico City area, as well as in the conurbated areas from the state of Mexico. So that's why you don't see this huge peak, no, that you see in the southeast of Mexico, in Tabasco, Chiapas, Campeche, and Yucatan. We saw these huge peaks, probably with a very high, very high attack rate, and then they went down. And on the contrary, in these large urban areas, I believe that the transmission is sustained and it's just increasing or decreasing for a very high to the medium high level of transmission.
Okay, another question is about prevention and your priorities and what are you doing for communicating and the questions with both EAMS employees and patients to help with prevention of COVID-19.
Yeah, well, with EAMS workers, we have been working very hardly. There is a specific unit that takes care of training and capacitation of EAMS workers that is increasing these efforts. And at the beginning of the epidemic, we had a lot of outbreaks in hospital settings because we in Mexico, we are not very used to have very strong influenza seasons. So people were relaxed and after a surgery or after, taking care of patients, they remove their mouth covers and they just share food and then we had these huge outbreaks, 15 people, 20 people. Now we are not seeing those type of outbreaks. And we don't see either, we'll say, second episodes of short-term respiratory disability. So I think we are doing better thanks to, I would say, immunity, and also that we have more training and more supplies for worker protections, EPPs.
And maybe could you, maybe shift gears? I don't see any new questions in the chat. Well, here comes one. How is he? So this maybe gets to the longitudinal
Yeah.
question.
Well, this is a very good question because, you know, although we provide guidelines very early, I mean, April 3rd, we provide guidelines on when and how to consider SARS-CoV-2 as an occupational disease. Even though we did that, we don't see virtually any claims as occupational disease. In Mexico, and I think in the US is similar, the responsibility for the claim rests in the worker. So if the worker is not well informed, then the disease is labeled as a general disease. And so what we are doing, and this is, sorry, let me just finish here. This is important because if you have a sequela for a general disease, your benefits are very different than if you have a sequela from occupational disease. So what we start looking is why people were not claiming their long-term disability as work-related. So right now we are calling in all the workers who have a long hospitalization, more than 28 days, to have review by occupational physicians and to detect those who might be of work-related disease and those who might have also a long-term complication. So that's what we are now doing proactively, to say so.
So for example, for the healthcare workers who have been sick, they're not filing claims.
They file in, say, if they have moderate disease, they filing claims because they can't work, no? And so but however, the claim is labeled as a general disease. So the worker is urged to go back because then it's living on 60% of his salary, and they suffer because that happens. So that's why we think that our claim rates are an underestimation of the true attack rate. Now, they do represent, because we see a high mortality, they do represent moderate or severely cases, because we do see a very high attack rate and a very high mortality.
So for example, just to continue, a physician or a nurse who becomes infected and has severe illness would still be counted as a, quote, general disease and not an occupational disease.
Depends. If he or she is a physician, a nurse, or a dietitian, or a pulmonary rehab, or anesthesiologist from IMSS, they will be labeled as, they will be classified as work-related. Now, from the private sector, because we provide insurance for all, say, the workforce of the private sector, they are not claiming. So if they don't claim this disability as work-related, meaning that the worker comes and says, I want you to consider my COVID-19 as a work-related, then they're not labeled as work-related, and they get less benefits. The worst case is when the worker dies and the family doesn't know their rights and they don't claim this as a work-related fatality. And in there, we are looking proactively at all deaths that are occurring in the health-related, say, private sector. And we are contacting families to help them with their claim. Okay. But that's unusual. I mean, that we had to ask for a special permit to do so.
Huh, interesting. So would this be a good time to shift to talk about potential avenues for collaboration, do you think? Or are there other
Oh
topics?
yeah, yeah, definitely. I mean, I think one of the issues that we are very interested in collaborating is with the long-term COVID-19, and because I think we will have to do a lot of collaborations to really define what is happening, you know, with these cases, what are the sequela they may have, and the spectrum and clinical areas of where the effects we might be seeing.
I wonder, I know some of us made a visit, of course, to meet with the team at Eames in December of 2019. Now it seems so long ago, but I wonder, I'm just checking, I don't know if Debashis, you're on this with us in this seminar, or anyone else from epidemiology biostatistics, just sort of to comment on an opportunity within the databases of Eames, or perhaps contacting individuals to better understand the long-term course of infections. So anybody have thoughts there about how we might think about working together? Please comment in chat, or we can unmute you.
There's also Marcela had some ideas also about that we already have been exploring.
Well, perhaps we should hear Marcela. Do you want to go ahead?
Hi, thank you, and thank you, Dr. Hernandez, for this wonderful talk. I think it gave a very detailed overview of what we're doing, and we have been working with Dr. Lee Newman and his team closely. So if anybody is interested, we could include you, of course, in this initiative. And we have data on injuries and other diseases like renal disease that we've already started working on using these work disability claims. So there's a whole area that we are wanting to explore there that is not only geared towards COVID, but also to other diseases and outcomes in workers, using data from these insurance claims. And yeah, we had a first workshop, but we're really open to any other ideas for collaboration.
So, I mean, I think one thing we will probably need to do is to convene a smaller group to discuss opportunities. Perhaps Mauricio, Marcela, can you comment on, you know, how such collaborations might proceed? I guess, you know, around designing studies or opportunities to collaborate on analyses. I know when last December, December 2019, when we met, we heard a lot about your data structure and work and how you've been, you know, improving it. It seems like there are issues related from how you would design a study nested within, you know, the enormous cohort of workers, to analysis, to whether you could actually potentially do some contact some workers, for example, doing nested studies to better explore certain outcomes. So comments there.
I think, John, what I mean, you see that we can do with the claims now, because we during the pandemic advanced incredibly with these claims analysis and systematization. So now you can virtually follow, say, any disease to the industry where the worker is giving his services or her services at this time. But you can also reconstruct the other employments that they have, because say the Social Security keeps, we keep records of all your formal employee years and where were you employed. So it is a very powerful database, and now when we share this data with industries, they realize, and they say, well, I mean, I wish I have this type of information to take decisions on what are really the health problems of my employees, because this health-related absenteeism is very costly for industries. So I think now we can move forward to see other ways of helping industries besides, I mean, telling them, oh, you're having an epidemic of COVID-19, beware. No? So,
yeah, right.
So I think you can do etiological studies, you can do many things. The other issue that I was wanting to raise, that I don't know if you are facing it as a decision in Colorado, is how to distribute vaccines, because I mean, at the end, there are two areas, no, that are being hit very hard by COVID-19: the livelihoods and the lives. No? And there is this discussion on where should we put vaccines, and I think, I mean, I would like to get some opinions from the occupational health faculties to see. I mean, are we really sure that the best strategy is to vaccinate 65 and older, or we should combine a strategy to vaccinate 65 and older and the workforce, no, in order to maintain the economic running and also to decrease transmission? Because as you see, in Mexico, workers are getting infected frequently. No, it's not say a free ride to go to work. No, but this is more. I mean, it's a combination of ethical. It's a combination of, say, occupational, economical, and I think at least in Mexico we have when we ask the priorities of the committees, we get an answer saying, well, a vaccine which is not applied in somebody 65 and older is not saving lives. So you shouldn't be applying it anywhere else. No? But I don't know.
Well,
it's a big dilemma, no? It's a big dilemma.
I'll be happy to share with you what Colorado is doing, and I suspect a similar discussion is going on everywhere. I mean, I think the governor's office has released repeatedly sort of updated vaccination guidelines, beginning with essential frontline healthcare workers and people in long-term care facilities, and then turning to those 75 plus, then 70 plus, then 65 plus. And, we work, our team here, our group that's doing the infectious disease modeling, works directly with the governor's office. And, of course, much of this depends on scenarios of vaccine availability, which is, still an unknown here. But, right now, somewhere around 100,000 doses per week. And, the scenarios with, J&J and increased production of the other vaccines would take it to, about 190,000 a week as sort of the maximum we might achieve. This is in a state of 6 million, of course, which is very small compared to, the Mexico City or, Mexico at large. The challenges that we're facing, I think, are similar. I mean, the questions of how do you achieve equity in so many different ways with any particular strategy. And, Colorado, like Mexico in many ways, has the challenge of rural locations and more limited healthcare facilities and how we will achieve access. So I will actually share with you separately some of the scenarios we've been working on and how long it might take to get to herd
The vaccine.
immunity, which is of course the goal. And we can share those sort of efforts with you because and of course there are people who are modeling different allocations of vaccine and trying to optimize, and it's certainly a challenge. I would that certainly is a potential area for collaboration. Who in Mexico is vaccine distribution, for example? Would EAMS handle the vaccine distribution for workers and others? How will vaccine allocation and administration be accomplished?
Well, it's been federally coordinated, and the idea is to make it at this point universally available to all Mexicans. However, there is, say, a list of priorities. No? The number one priority was people who were first responders, but medical first responders, not say the big and ample distribution that you have in the U.S. as first responders. Here was only vaccination of the say the workforce which is involved with COVID-19 direct attention. So that was the first one. Now we are struggling to get the rest of the health personnel, and then they're coming 65 and older. Then after 65 and older, then adults by 10 years of age with chronic conditions, 50, 40 and plus, and then for some reason teachers appear somewhere in the priority. Teachers in states which are in low transmission, but workers are never mentioned. I mean, it's like we don't exist, no? So that's why we are struggling to get. I mean, the EAMS is directed by three groups: the federal government, the unions, and the employers. And employers have been very hard voicing the fact that they want to buy vaccines to vaccinate all their workers. No? Even in a solidarity scheme, saying we buy 2 vaccines per each worker we have, so that we can vaccinate all the workers from the micro industry to the giant industries. But this is impossible because there's no way to get vaccines if you are not a government, no? At this point
Yes.
in time. No? So, but that's how we're doing, and it's difficult.
Yeah, I can certainly share with you what Colorado is doing. And of course, different states are doing things in different in different ways in this country too. And putting aside how much vaccine is allocated to each state from the federal government to how it's actually being used once it arrives in the state, or the different complexities of implementing vaccination programs. I wonder, before we run out of time, if there's anybody else who wants to raise anything in the chat. I think a good follow-up would be for those who would see opportunities potentially for collaboration with EAMS and Mauricio and his team to write to me. I think definitely we should organize some follow-up discussions. Perhaps maybe Mauricio, Marcela, highest priority would be the follow-up activities potentially around thinking about questions of long-term impact. Is that a
well? I was going to say, coming back to your original questions, that maybe, I mean, because any research efforts needs money, and I think that now there's going to be a lot of interest, no, in defining exactly what's happening with COVID, what's the impact, and there are also other issues. I mean, if we are very much also interested in looking at the model if we start getting new claims, no, in workers, and how long it's going to pass before they claim another COVID-19 claim, no, another short-term disability, because this give you a very nice set to really monitor what type of immunity we have, no? We have the limitation that we are not doing PCR to all, but we know who had a PCR confirmed cases, and we're doing some serology to monitor what's the immunity rate in the population, and so we are open to any collaboration. I was mentioning the long-term COVID because I'm sure we're going to be easier to find funding for that type of research, because I think it's a need, it's an urgent need to define.
Yeah, a quick question. Do you anticipate much so-called vaccine hesitancy in Mexico?
Not much, but it's worrisome how much noise we see in the web, the internet and you know, we have the Chinese vaccine, we have the Russian vaccine, we have the US, European, and people get very, very confused about the quality of each, and also, I mean, the Russian vaccine was, I mean, approved without passing through the general scientific reassurance that we will expect, no? So that is making us, but I don't think we see that much. Look, we vaccinated some of the private frontline physicians and nurses and health personnel, and we had 20% no show, for example.
Okay, that's.
But it was a big trip. I mean, because you had to go to an army base, 1 hour drive, get vaccinated, and I think it was a good turnaround. You know, 80% of people who were scheduled arrived.
So there's a question in the Q&A just about when Mexico turns to vaccinating younger people, youth, do you think that will be done through the schools?
Yes, no, definitely. We do vaccinate in schools a lot. I mean, for example, HPV is a vaccine that is delivered via the school system. The measles second dose, the triple, also is given in schools when the first graders are coming in. So.
Great. So I'm going to suggest that we.
But maybe Marcela can put her email in the chat. I don't know, Marcela, if you can put your email so anybody who is interested can reach you and we can.
And that's good. And
let me find where the chat here.
And certainly use my my email as well, and we can make sure that connections are made. And I think, Mauricio, you and I can speak probably particularly about organizing a smaller group to talk about the longer term follow-up and what are sort of funding opportunities, I think. And I have some thoughts about how we might do that.
That would be good.
Let's see. So, great. So, any last comments that you would like to offer, Mauricio?
Well, we didn't really show the model, but we are with all the information that we have, we build up a predictive model that help us to send an alert to the different businesses that are in our platform, so that they may be experiencing a change in incidents, and they should revise their filters or their activities. And it's a nice, I think we have never had so much information about outbreaks in the work setting.
Right.
So if you want them, we can show that's a paper we want to write, and maybe some of your modelers would like to join with Rodrigo and Manuel Ortega, who are leading that team.
So maybe we should have two follow-up meetings, and a modeling and a long-term meeting.
Mm-hmm.
So I think I want to thank everyone who joined us, and thank you to Mauricio and his team. I particularly want to thank Cindy and Patricia, who worked together to organize all of this. And I hope we are all vaccinated soon. And I'm glad to see your epidemic curve is going down nicely, as is ours. And let's hope that continues, and pesky variants don't show up to make things worse. So thanks to all, and Mauricio, Marcelo, I'll be in touch and follow up.
No, thank you, John, and all colleagues from the Colorado School of Public Health. Thank you very much for having us in this seminar, and we look forward for collaboration. So please let us know any ideas or things
Let's get started. Like to do. Good. Bye to all. Adios a todos.
Thank you. Bye-bye.
Bye-bye.
Bye.